Duty. I appreciate that warm welcome. I apologize. Just give me 2 more minutes, and if we can kindly resume in 2 minutes, I will appreciate that. This afternoon is advances in diagnosing pediatric TB, the utility of various tests. I'll talk a little bit about various specimens and touch a bit about what imaging aspects that we could consider in pediatric TB. Thank you for this opportunity. Can you hear me?
Juti? Yes, loud and clear, Dr. Marangu. Go ahead.
Thank you. Good afternoon. And thank you for the opportunity of to talk about advances in diagnosing pediatric TB. This remains a big challenge. However, we'll discuss ways in which we could improve modalities in diagnosing pediatric TB and putting them into care in a timely way. So in TB, in children, when we diagnose TB, most of the time it's largely a clinical diagnosis. And we have the guidelines that are out there, including the 2021 guidelines. And clinically diagnosed TB is when a child has 2 or more of the following suggestive symptoms: the cough, we talked about chronic cough, the fever, poor weight gain, and lethargy. And for these children, then we suspect TB. More importantly, we ask about whether they have had a positive contact. We assess for respiratory signs. We look at imaging such as an abnormal chest radiograph, and we may perform a MAN2 test, which if positive, helps to clinch the diagnosis. Sometimes this diagnosis may seem to be difficult, but I think what Prof. Obimbo and other colleagues in prior talks have explained, how to simplify this diagnosis. And with this suggestive symptoms and additional history and signs and investigations, we can confidently say that this child has TB. However, we should always strive to confirm TB bacteriologically. We know this is not possible all the time, but it's important we at least make the effort to bacteriologically confirm TB. And when that specimen is positive, then we say that is a bacteriologically confirmed case of tuberculosis. Okay. So TB, we know it. It's a rod-shaped bacillus. It's acid-fast. It multiplies slowly. So that's why in terms of culture, it will take a while. Its cell wall is made of this lipoarabinomannan, which is the basis of the LAM test. And we'll touch a little bit about that. And on microscopy, we can do light microscopy or even fluorescent microscopy. You'd require at least 5,000 bacilli for every ml to get a positive result. And it can be non-specific, especially, for example, for non-tuberculous mycobacteria. The turnaround time is pretty fast, in 2 hours. And we'll discuss its sensitivity, which is not really good in children. Culture takes about 8 weeks. It's slow. You need about at least 10 bacilli for a positive result. It's confirmatory. And the good thing about culture, it can distinguish Mycobacteria tuberculosis, the complex, from non-tuberculous mycobacteria. And it's useful in monitoring treatment and outcomes. And we know we have liquid cultures, which are a bit shorter in terms of turnaround time, about 6 weeks. And there are also other modalities where you can culture the microcolonies, the modes, and here you have about 14 days. These are all known ways in terms of bacteriological tests, but I thought it's important to put this as a background. The infrastructure is much cheaper than liquid culture. Molecular techniques are the ones that we currently using, and we use this to diagnose TB through amplification of nucleic acids, be it DNA or RNA. And they're also useful in detecting drug resistance because we can identify the genetic mutations that are responsible in the bacteria. So what we all know about is XPAT, which is an automated real-time PCR technique. And now we have XPAT Ultra, which has higher sensitivity, especially for persons who are possibacillary, so that's the SPM positive and HIV positive. Then we do have line probe assays, and I won't go into too much detail about that, but especially when we're beginning to think about resistance and helping us guide us in our treatment. So this was really just more of a preamble to know about our bacteriological tests that we have. And now I'll tailor this talk more to children. When we talk about sampling respiratory specimens, specifically for pulmonary tuberculosis, these are the three I would perhaps put forward to us and that we know of: nasopharyngeal aspirates, induced sputum, and bronchoalveolar lavage. Okay, a nasopharyngeal aspirate. So in this image, I don't know if you can see my cursor. This is a mucus extractor. Behind there, you have the suction machine. And within the mucus extractor, there's a catheter aspect that you insert into the nasopharynx. And to a depth of from the nose here to the tragus, that's the depth for the nasopharynx. And if you suction that would be a nasopharyngeal aspirate. The difference between that and an induced sputum is that prior to taking the specimen, the child will be nebulized with hypertonic saline and some salbutamol to induce the sputum. The salbutamol there is to prevent the bronchospasm that is coming about by the hypertonic saline, and that will induce cough. So you'll get more of a lower respiratory tract specimen. And when you aspirate it, be it with this technique, or perhaps for children who are much older and can expectorate, then that will be an induced sputum. So we know induced sputums can be done safely, even from as early as the age of 2 months. And this is something that we do commonly. We can get lower respiratory tract, another lower respiratory tract specimen through bronchoscopy. This is a more invasive technique. And we do have bronchoscopy for children here at Kenyatta National Hospital. And we insert the bronchoscope and we're able to lavage us and get us a bronchoalveolar lavage specimen. And we can also take this for diagnosing tuberculosis and many other respiratory infections as well. So it was important for me to spend some time here just to share what are the respiratory specimens that we can take for pulmonary TB. And this can be for also other respiratory infections. We do also have non-respiratory specimens for TB. And here I'm speaking about pulmonary tuberculosis. We do know about the gastric aspirate, and we have good protocols even within our TB guidelines that explain this. This is something we've done, I think, for a much longer period of time. And I think the only difference is, again, you could say it's invasive, and sometimes you may not be able to do this in the outpatient setting. And sometimes children may need to be admitted overnight so that you can take the early morning specimen. Stool is so going back just to reiterate, these are all spot. This can be taken at any other time, not necessarily in the morning. Stool is also a specimen that has been explored in the literature, and we'll look at the evidence for this when it comes to pulmonary tuberculosis. And it's in use for now. And then also urine. And there are different tests that have been used, mainly molecular ones, when we are attempting, or we are striving to make a diagnosis about to confirm TB bacteriologically. So this is for pulmonary tuberculosis. Remember, we do have extrapulmonary TB and other specimens. For example, if we're considering TB meningitis, CSF, if you're considering TB disease in the urinary tract, then urine, and so on and so forth. So then this next segment, I'll spend some time. I see some hands are being raised. I hope everything's okay.
Yes, it's okay. Please proceed.
Okay. Yeah. So in terms of the diagnostic accuracy, I'm going to spend time on various specimens, as I've highlighted, nasopharyngeal aspirates, induced sputums, gastric aspirates, and stool. And then focus on expert and ultra, because these are much more sensitive modalities, especially in children, and we'll just look at the data and the evidence for this. So I'm just picking a few papers. So this might not be very recent, but we have a nice Cochrane review that summarizes all this. But in 2015, Detian and colleagues, they looked at about almost 4,000 children who had been investigated for tuberculosis. And these children had, as we can see, there are more number of respiratory specimens, so probably more than once. And this was actually a systematic review and a meta-analysis. So they've looked at different studies. So there are 15 studies that looked at this type of children. And culture is usually seen to be the reference. Now, for tuberculosis, there's no good gold standard. But most of the time when you're discussing sensitivity and specificity, the reference test is taken to be culture. So in all this number of children, in these 15 studies, we see that the culture test, out of the 3,640 children, only 420 were positive for TB, 12%. Just again, really resounding the fact that culture, positive culture, is hard to get in children, and really that clinical diagnosis is very important. Now, expert was positive in about 11%. So you can see here, expert and culture are kind of going hand in hand. So despite all these children who were suspected to have TB, you can see such a small number, almost like 1 in 10. So in the meta-analysis, and they kind of looked at the sensitivity, specificity, of course, again, I mentioned by culture, against culture. And here in this red rectangle, we do see, this is expectorated sputum, this is induced sputum. And you do see the sensitivity looks to be somehow higher. So as you approach 1, it's higher. And then we do see for gastric fluid, and we see this in nasopharyngeal aspirate, not too good. Specificity is pretty high for all of these tests. So a pooled sensitivity of about 62%, not so good. And pooled here sensitivity of about 66% here for gastric fluid. So I'm comparing this sputum and gastric fluid, but not too far from each other. So from this systematic review and meta-analysis, they did show that expert offers a better sensitivity, of course, if you compare that with microscopy. But we're cautioning all of us that a negative expert does not rule out tuberculosis, and still that, good clinical acumen is what's needed when we are trying to decide whether this child needs to start anti-TBs as we look for better diagnostic and continue our research in this endeavor. So some good news, but maybe not the best of news. So Ultra, Expert Ultra, it's in children. So that was a prospective study, and there've been a number of studies that have been done after this, but I just wanted to highlight how there seemed to be a better overall sensitivity. Some studies show similar, others better. So you do see there about 84.8% in comparison to about 81%. So when it came to cases, Ultra showed better detection. And we'll look at a nice summary table looking at this. Then stool. So colleagues have, depending on your context and perhaps what you're used to, some people find induced sputum difficult. I think it's very simple to do. Others may find gastric lavage very difficult, yet, I think it's what you understand. These are all not hard procedures to do. But I think for all of us, we're looking for how to make the diagnosis simpler and simpler. And that's why alternative specimens have been explored, including Stool Expert. Again, through systematic reviews and meta-analysis, there's a lot of pooling of the data. And what we could see here, so this is a forest plot. Here, this is the sensitivity, this is the specificity, and we're looking at how stool compares to the microbiological reference standard. That's on a respiratory sample. And most of the sensitivity here was around 67%. Specificity always, I think, really great at 99%. So we've seen 66, 67%, be it respiratory samples, be it in stool. And then it's in children who had HIV, the sensitivity was seen to be much higher. So 79% compared to the 60%. So still looking good, especially in children who have HIV. And then just, so I think, again, when we look and you're pooling studies, they've been done maybe differently. So that's what they mean by heterogeneity. There are a number of differences that are there. And sometimes in the analysis, the groups who under 5 are not well represented. And this is the most relevant target population. We know these are the children who are really at risk. So being an non-invasive method, it could be used to rule in TB, especially in those who have HIV. So, and again, most of this research calls for, standardized approaches as you prepare the stool testing protocols so that they can be more generalizable, and calling for the focus of more research to be done in children under 5. I liked this Cochrane review, where they were looking at Expert and comparing it to Ultra. Now, these are two good molecular techniques, but now showing us through, pulling the different studies. Of course, Ultra being new, you'll see that the number of participants might be fewer, but they did it nicely because, you're able to see how does it perform on induced sputum, how does it perform on gastric aspirate, nasopharyngeal aspirate. These are the 3 respiratory specimens, and an invasive non-respiratory sample like stool. And you see that Ultra here appears to be more sensitive on induced sputum, a bit less in the gastric aspirate, similar in nasopharyngeal aspirate, and a bit lower in stool. But again, maybe perhaps the studies are fewer and the data is going to be emerging. But it's just important to appreciate that ultra could be more sensitive, and even for rolling it while in our country nationwide. So here I'm going to just speak around, where the gaps are in research. A nice article by Wabudaya and colleagues, what are the issues and what can be done in terms of advancing, and maybe these are the opportunities for research in our setting. So we see that, with multiple specimens, different types, perhaps the yield increases, and not just only having different specimens, but repeating these specimens perhaps increases the diagnostic yield. And it might be induced sputum, a spot, and then in 24 hours it's repeated, or in 6 hours it's repeated, or combinations of induced sputum and gastric aspirate, so on and so forth. And these have been reported in a few studies. But I think, getting that right combination to increase the yield, that is not well known, but we do have studies that show that more than one specimen and more than one specimen type will help increase the diagnostic yield. But there's more research that is being called for. And then, in addition to combining the traditional approaches, also having more advanced approaches, some maybe perhaps that are more in the research front at the moment, but hopefully, will become more in the public domain. Again, this is research that is needed. Also, when it comes to culturing, seeing what methods could be able to enhance the viability and the growth of this bacilli. Looking at LAM, so I did talk about, I think I focused my talk on molecular techniques, but we do have, for example, tests that are looking at that coating around the mycobacteria, the Lipoarabinomannan. And assays, we've seen that data from the adults do show, like, for example, in HIV infected persons, that the diagnostic utility is higher, but also looking at now LAM assays in severely malnourished children, how does that work? And beyond just taking stool and other non-invasive samples, simplifying it to the extent of, maybe just an oral swab. That could be even simpler. So there's a lot when it comes to, the performance of tests and how sample collection methods could be improved, that can be looked into from a research point of view. So, but nonetheless, in our context, I think I just want to reiterate, as we strive for that, all this, the induced sputum, the gastric lavage, be it bronchoalveolar lavages if needed, these can all be done in our settings. So, and they're not hard to do. It's a mindset. It's when you do them and you get used to them, I think it's something that we need to strive. Even though we have seen, when compared to culture, it's not the best. However, as we strive to get our samples and specimens, then we'll see whether we are getting much more confirmed, bacteriologically confirmed TB in our setting. But we can't despair and just say, hey, this sensitivity is too low, it's not worth doing. I think it's always worth striving for it. But remember, we are clinicians first and foremost. And if the child fits this bill and we have strived, and despite the negative test, we can always start the anti-TB medication, but following up these patients and of course, referring when needed. So Wabudaya again and colleagues, talk about, what are the opportunities in placing these tests in pediatric diagnostic algorithms. I think for the TB program in our country, already this has been done. And from a very early time where, yes, we have the clinical diagnosis, but the wording is very good. We strive to see if we can confirm this bacteriologically. So, talking about when you start, who you screen, who you refer, and, not delaying treatment initiation because of being stuck. I think Prof. Bimbo and others have really, really taught us well when it comes to, simplifying the diagnosis of tuberculosis. Okay. Also, lots of research needed in terms of implementation. How do these tests impact morbidity? How do they impact mortality, treatment outcomes? Are they cost effective? What's the budget impact? Are they feasible? Are they acceptable? So these are all research areas that we could look into. And then also, what are the novel tests that can be done, can be created, tests that are more sensitive and more specific, especially for active disease. Sometimes differentiating latent and active disease. But children who are already symptomatic, then that's taken as active disease. But it'll be very interesting to see if there are more sensitive tests, especially for active disease in children. I want to stop here for a bit, but this segment that I just finished was really about, diagnostics and tests from more of a microbiological perspective. I have just 2 more slides, and then I hope to be more interactive in discussions, where I want to put in a plug also for what we know commonly as imaging, and just touch a little bit on what I have seen is topical or being discussed when it comes to diagnosis of tuberculosis in children. So ultrasound, we've talked about ultrasound, I think previously in children, especially for pneumonia. But there's quite a bit of work when it comes to
Hello. Oh, sorry. I think we have a problem. If the host could mute the other people. Nelson, please mute other people. Dr. Marangu, please continue.
Thank you, Jyoti. So ultrasound, thoracic ultrasound for TB diagnosis. I know the adults have really, I think, gotten on the bandwagon much faster. There are a number of devices, standard and novel ultrasound devices that just help make diagnosis easier, and different protocols that people are trying to help in this diagnosis, combining what's in the chest and looking at in the abdomen, in the neck, and so on and so forth. I just thought I should put in a plug for that. And also the chest radiograph, what's seen to be very simple. We've had, I think, talks before. I think where I have done a talk on diagnosing tuberculosis on chest radiography. And there's a new, the TB Atlas I talked about by Professor Guy and others. There's a new version that's available. And I think I'll share the link at the end of this slide. So this is what I had prepared for us in terms of advances in diagnosis of tuberculosis, really focusing on the molecular work, technologies that are out there, comparing them for children in the different specimens, and just putting in a plug for these other modalities that we do use in helping us diagnose TB. Thank you, Jyoti, and over to you.
Okay, thank you very much. That was a very concise yet comprehensive overview of all the investigations, or most of the investigations that are available to us. Thank you for letting us know what we can do now here in Kenya. We have a few questions in the Q&A section, and I think we can address two of them at the same time. So, what is the role of a Mantoux test in the diagnosis of TB in children, and the TB scoring chart in diagnosis of TB in children?
Thank you very much, Jyoti. Sorry. Can you still see? And I'll just come here. So Mantoux test, your tuberculin skin test, I think is still a very important test, especially in children, because it shows us whether there has been previous, there's been infection, where they, especially, and we know children who are under 5, their risk of moving from infection to active disease. We have that nice table by Murray and colleagues showing in under ones that risk is really, really high and keeps decreasing. But compared to those who are over 5 and under 5s are more at risk of moving from infection to disease. Now, in a child who is symptomatic with a positive Mantoux test, then this is really TB disease. Of course, we do know that with after BCG vaccination, you may have a positive Mantoux, but in children who are symptomatic, your Mantoux is positive. The child is symptomatic. You have features that are suggestive on chest radiography. Then this is a very important test that unfortunately has, fallen out. It was really a big thing. I think it's because the adults, got it out of the algorithm. Remember them, by the time you're getting to adulthood, there's been lots of exposures. But in these young children, that does show us infection. And in the right context, therefore, for me, this is a diagnosis of tuberculosis. And treatment should be initiated. We should be confident about it.
Yeah, I think perhaps we should also have a serious talk with perhaps our colleagues who run TB clinics, because they are so used to dealing with adults, like you say, they don't really understand what we are talking about when we say the clinical diagnosis, or based on having a chest X-ray or a Mantoux test. So I think, we probably ought to package diagnosis of TB in children as a separate algorithm more clearly to those who dispense the medication. Probably would be more helpful to us.
Even in the current guidelines, Jyoti, this is true. And this was actually a much older guideline that I'm sharing here. I just like the way it had been put. But even in the 2021 guidelines, there's a section. The 2021 guidelines have both adults and children in the same guideline, which is really nice.
Yes.
And the talk about the positive Mantoux is actually very well detailed in there. So, but as you said, that's very important. Thank you.
Okay. So we do have a few more questions. Kevin asks that gene experts for gastric aspirates for TB diagnosis in pediatric patients usually turn negative. What is the recommended test?
Maybe I didn't get the question very well. The recommended test. So how will I put this? Let me get to one of the slides, 1 minute.
Sure.
Okay. So we started off by talking about respiratory specimens and non-respiratory specimens that are for pulmonary, diagnosing pulmonary tuberculosis. Yeah. So in all these tests, be it expectorated or induced sputum, samples, be it a gastric aspirate, an nasopharyngeal aspirate, and then non-respiratory specimen like stool, you can do expert or ultra in them. So, and these are all WHO approved samples for expert or expert ultra. I don't know if I understood the question well, and maybe you can, if I haven't answered it well, maybe you can help me maybe ask it in a different way.
Sure. I think the concern in this question is for a patient who you suspect TB and you did a gastric aspirate and it turned out to be negative. I think that the slide that you had shown us before would be very helpful in deciding whether or not to treat the patient for TB, because we said that we are going to use the clinical diagnosis of TB. And as you said, we should strive to do the confirmatory tests, but if we are highly suspicious that the patient does have TB, we should go ahead and treat. I think maybe
absolutely, Judy. Absolutely, Judy. And the reason why we spoke about this, and I think I shared this very sobering systematic review done in 2015, is despite all, these are all the number of children who are investigated for TB. You can see there are almost 4,000 children. And in 12%, do you find a positive culture? And in 11%, do you find a positive expert? So you can see that you have 100 children, and in 11 of them, so you suspect, and they probably have TB. I mean, clinically, you have this diagnosis, but only in about 11 of these children will that expert be positive. I don't know if that's quite sobering.
It is.
Yeah.
It is. And I think it's part of sorry.
Go ahead, Juti.
Yeah, I think, and it's part of the message that you're passing, and what Prof. Obimo had also spoken about previously, is that in pediatrics, we are more focused on treating the patient, and that's why we have the scoring system. And based on what you told us about the clinical acumen of diagnosing the TB, yes, we should try to do the investigations, but we should not ignore the clinical features in the patient.
Absolutely, Juti. Your clinical diagnosis, it's simplified, and it's just what we had spoken to. The first slide, I think, of this presentation is exactly that. I'll leave it here so that we can, as we discuss, it's nice that we are talking about these advances and all, but it's also important to show you, despite the advances, where the gaps are. So this clinically diagnosed patient, this child, we should be confident if you have 2 or more of these suggestive symptoms and 2 or more of these other findings, then you can clinically diagnose TB. It's a different story if you put this child on treatment, they're not improving, then that's a child whom you want to refer. But you shouldn't say, oh, I can't do a gastric lavage, or I can't do this, or I can't do that, or it's negative, then we can't say this is TB. You should have the confidence to be able not to delay treatment if it's warranted, and refer if there are any other doubts, but start the treatment, initiate the treatment, have the confidence to say, this is clinically diagnosed TB by our national guidelines, which are borrowed heavily from the WHO guidelines, and go ahead, initiate your treatment. But do strive to obtain a specimen that could help bacteriologically confirm the TB. The benefit of that is, for example, especially if you're worried about resistant TB and other things like that, and that documentation, how did this child improve? Did they get better? Are they worsening despite the treatment? Then now if they're not getting better, they're worsening, that's that child, then they're on the treatment, refer them. We will see them. Perhaps it's something else, but you did the right thing for this child by initiating the treatment, given this clinical diagnosis. Indeed, you strived to get a bacteriological confirmation with the specimen that you could. So that's important. And all these specimens are all very easy, especially induced sputum and gastric aspirate and stool. Those are very easy to obtain and do in all our settings, I think, across the board in the country. Yeah.
Okay. We have another interesting question here. Someone asks, they say great presentation. We have been getting a lot of positive urine lamb despite the patient not having symptoms of TB. Should we start them on anti-TBs irrespective of other positive findings?
Maybe my question, that's an interesting question. First of all,
it is.
Thank you. And it's really nice. And maybe if they get a chance to admit themselves later, depending on your duty, I'd like to do a little bit more where they come from and where is this. But what I'd ask as a question is, why did you do the urine lamb in the first place? Because remember, we are clinicians. It's usually when you have a clinical question that you'll do a diagnostic. Yeah. So if this child you did not think TB was a diagnosis, why was lamb done? I'm just curious as a question.
Yeah.
So maybe just a little bit of context, the person maybe could expound a little bit why the lamb.
I think they should. Maybe could you, whoever asked that question, maybe you can just message, add it to the chat, or just message me privately so that we can find out. Because I agree with Dr. Diana, what were you suspecting?
Yeah.
Other than TB.
But that's interesting. Why that would come up. But remember, this is it's looking at the coating of the mycobacterium, and there may be other reasons why that is. I'm not sure, but it's interesting that this has been done, and that maybe better to have a little bit more context to be able to understand and answer appropriately. Okay.
While we wait for the response, I have another very interesting question from Winnie, who says, great presentation. When checking for TB contact, how long back should we go? How many months prior or years to the presentation of the child?
Yeah, so again, it depends on the age of the child, I guess. I think I will put it that way. If you have a 6-month-old who has a positive contact, so this child has been exposed. So maybe I've not understood maybe the question from that aspect, but if this is a 6-month-old baby, they have a contact of tuberculosis. I mean, for me, and they're symptomatic, that's really important history. 1 year. So our TB guidelines do give us, in terms of range of that history of contact, but I think it also it has to be in context of this patient. So especially if they're under 5, remember, if they've been exposed to tuberculosis, their risk of moving from infection to disease is high. And that's why children who are not symptomatic, and I'm just deviating a little bit, but do have a positive contact, then we put them on TB preventive therapy, because you really don't want to move. You don't want to miss that. You don't want to have that risk of getting to active disease. So maybe I'll ask to expound, Juti, what do you mean by duration of contact, from which angle?
I think maybe because perhaps this is a question that the audience may be having on either angle, perhaps we should say that in terms of active case finding, is that we should not only look at the duration that the person has been, the current patient has been in contact with somebody who is suspected or being treated to having TB, but how long ago. For example, a case of a grandfather who died a year ago who had TB, and the patient is presenting at the moment. I think from those two angles. But either way, I think from what I understood is it should be what you've just said, like based on the age of the patient and based on the current presentation, because for the younger children, the risk of contact, it still applies either way, I think.
Yeah.
I think you answered the question. So I think we have some and the response from the person who was asking about the urine lamp, I hope, and they said that this is it's more of a comment from the microbiology side, with the expert in RIF assay, is designed for sputum samples, and the validation is based on that. Oh no, this is a different one. So the use of the test on other sample needs extra validation on verification from the lab side before commencing patient testing using other samples. I think perhaps they mean that you should find out from your lab whether you can do expert on the other things.
Yeah, that's true. I think your context is very important. That Cochrane review, that summary I shared with you, comparing
Yes.
and expert, and those are WHO recommendations. And remember, when we get these guidelines, our national TB program also looks into them and validates them. So again, it's based on your context and know your lab. Yeah. But these are globally approved. These are globally approved specimens that are being used for TB diagnosis in children.
Okay. Thank you. I think we have a bit more time for a few more questions, and I see quite an interesting one here. Is there a role for task shifting when it comes to sample collection in areas with no clinicians? And also, are there facilities that allow for remote X-ray reporting? Because this is often a bottleneck. Is there a training curriculum on sample collection for other cadres?
Very good questions, very interesting questions. Again, I'll just say it's about your context. We've seen how we said, like, for example, in ETAT, you can train triage. Who can triage? Do you remember when we're talking about ETAT?
Everyone.
Training everyone, yeah. I would say the same thing if well taught. I know this is being recorded, but I think these techniques can be learned by any health worker. I'll put it that way for now. And in our settings, and we see even in our own settings, we have chest physiotherapists, the nurses, the doctor. So it's all of us. I don't know which cadre they were talking about. Is it a non-health worker or health workers? But all health workers really can take any of these specimens. But maybe Juti, you can just, in case I got that wrong.
No, I think they're referring to a nurse, if I'm not a nursing staff, because the dispensaries and the lower facilities are usually manned by nurses, and I think they mean if they're not doctors.
Absolutely. No, this is not taking these samples is not only a doctor who can do this. Actually, most of the nurses, clinical officers, chest physiotherapists, health workers, I would say actually in the health setting, you can be taught how to take them there. It's not a difficult thing to do.
And I think
I wouldn't call it task shifting per se. I think this is This would you. We are a team of health workers, and this is where I would say yes, absolutely. In the dispensary, the nurse should be able to take this a specimen. This is not difficult at all. Yeah.
I think also perhaps the facility that you're in, whoever asked the question, perhaps you should request some assistance from the Ministry of Health, because a few years back, there was a group of people who were teaching staff, not only medical doctors, mostly the nurses and the physiotherapists, on how to take, for example, the gastric aspirates. So perhaps you can request for your facility to be taught if it's if it's something that you're interested in knowing, I think. Okay. Dr. Marango, I think we're almost at the top of the hour. We have very many very interesting and diverse questions, but I think we've answered most based on what you've taught us today. Perhaps you have a parting shot to tell us, or take home message.
Yeah, just reflecting on, I think, the person who was talking about the contact, maybe in the perspective you are looking at. When we talk about our guidelines, and explicitly in the 2021 guidelines, they talk about within the last 2 years, but again, I think you have to really take this in context, but this is explicit wording in our current guidelines. My parting shot, Dr. Juti, is TB in children is really a clinical diagnosis. However, we must strive to confirm it bacteriologically, and it is doable in all our contexts. And we've seen that the sensitivity does increase, the diagnostic yield does increase, and we've seen in terms of the evidence, when you have more than one sample, and also having multiple specimen as well. So I would urge all of us, as we take care of our children, to have a high index of suspicion for tuberculosis in the children whom we care for. Strive for that bacteriological diagnosis, treat clinically. If not responding as you had expected, refer in a timely manner. Thank you.
Thank you very much, Dr. Diana. That was very interesting. I'd like to remind the participants of the previous presentations that we had, particularly those expounding on the new guidelines for TB diagnosis. It's available on the YouTube channel, KNH's YouTube channel. Please check it out. And please spread this word. We really need to kick TB out of Kenya, hopefully soon. So thank you very much for attending this afternoon's webinar. Please feel free to join us tomorrow. There are several very interesting topics, as you can see, demonstrated, and you can view the previous webinars and see what's coming up on the KNH website. Thank you very much and have a lovely afternoon.